It's always a question in people's mind is how can I learn this procedure and do it in such a way that it's not anxiety provoking? And after about 300 of these, I have found that I think it's just taking it slowly in terms of doing it. Because SuperPath is so close to being a normal posterior approach, it really is not that much different. So you can start off just doing SuperPaths like I did for patients that have hip fractures. They're older folks, you need to preserve their tissue more probably than anyone else. But if you have to get to a point where you can't quite do the SuperPath technique and you have to release some tendons to the piriformis, short external rotators, you can do that easily, converting it to more of a traditional posterior approach.
An additional strength to the SuperPath technique is the fact that it's part of a larger approach. And I think this is probably the single most important strength to this approach. The fact that this procedure is very easily adjustable and is convertible to your standard posterior approach and can theoretically be extended all the way down from the hip to the knee means that not only can you do this safely and slowly within your own comfortable learning curve without a safety deficit, but it also means that you can use this same approach to facilitate some of your larger surgeries. Like crowfoot dysplasia, where you need a turn-up, turn-down, or a subtrochanteric osteotomy, where you need bone graft for a femur, where you need a large acetabular cage cup revision. These are all cases that can be easily done, have been published as done through a SuperPath modified approach without having to destabilize the hip. And these are things that are very exciting because the surgeon can really decide what is comfortable for him using some techniques and technologies that truly make sense.
The thing that really interested me and I thought was very unique about SuperPath is that it allowed for a surgery to be done in a minimally invasive technique, a very tissue-sparing technique, but that utilized a very similar and familiar approach to what I was already using. And I could do it with the equipment that I had in my hospital already. I didn't have to buy special equipment or tables. Everything was very easily converted over to a traditional approach to SuperPath. And so not only did it allow for that ease of transition, but intraoperatively it allows for a lot of flexibility. Should there be any sort of complication that needs to be addressed, or should you need to convert to a more extensile exposure, you can do that seamlessly with SuperPath and maybe limited with some other approaches. The key was stepping back and not incorporating all of the elements of SuperPath at once. Rather, taking a stepwise approach as you integrate SuperPath into your practice, and for my practice was really instrumental in sort of allowing that learning curve to progress at a natural pace. And then as I got good at certain facets of SuperPath, then I could start incorporating other aspects of it till ultimately you can put the whole package together.
I think one of the most important things that I learned early in the SuperPath learning curve, and I try to impart this to people that are just starting, no matter how much you struggle with those first 3 or 4 cases, and you may or may not, you will absolutely see a vast improvement in what your patients are able to do the next day, regardless. I had one case, like my 3rd or 4th case, which took 4 hours for a number of reasons. And that patient did fabulous, just as well as a patient that takes me an hour to do, and where there's no hiccups whatsoever. So as long as you maintain the respect of the soft tissues and the approach allows you to do that, you really get the same result regardless of how hard the case was. You got to be persistent for a while. If you give up early, you're going to miss out.